Okay, Reggie? 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 Here we go. Here we go. All right, real quick review, real quick, because I knew you weren't paying attention on Monday, and there wasn't much to pay attention to. Which side of the heart pumps more blood, the right or the left? Which side of the heart works harder, right or the left? Which side of the heart contracts first, the right or the left? Which contracts first, the atria or the ventricles? That's good. Okay. All right. Here, I'm going to give you a hint because I like it. Ready? Ready? What determines the amount of venous blood pumped by the right side of the heart? Right. See how venous blood is coming back to the heart? That was the hint. What? What's wrong with you guys? Maybe it's me. Ready? Better write this down. You probably did. The amount of blood pumped by the right side of the heart is determined by the amount of venous blood that's returned to it. That has a term. It's called preload. Tell me you got that. Who's with me? Guys? Okay. So, venous return dictates the amount of blood pumped by the right heart. What determines the amount of blood pumped by the left heart? The amount of blood that's pumped by the right heart. You got me? Who's paying attention to this? Anybody?
Yes.
Okay, so watch. So what you can do, and I explained this to you before, and it's an important concept. If venous return determines the amount of blood pumped by the right heart, and the right heart pumps the same amount of blood as the left heart because the right heart determines how much blood pumped by the left heart, then you can skip a step and say that the amount of blood pumped by the left heart is determined by the amount of venous return to the right heart. Do you understand that? So anything that interferes with venous return of blood to the right side of the heart is going to affect how much blood is pumped by the left side of the heart. Do you follow that? Yes or no? Okay. Now, with that said, I'm going to show you where you use ATP right now for the first time in your life. We talked about it for about 1 million years, and now you're going to learn. And you will learn. Why the hell won't this work? There we go. Okay. I'm going to explain this whole thing. You got me? I'm going to explain to you how cardiac muscle contracts. And I want this whole thing. Are you with me? Okay. This is, okay. Here we go. Let me explain a few things first. Write this down. Write this down. There are two main contractile proteins in cardiac muscle contraction. They're called actin. This is actin, and then you have myosin. Are you with me? Hanging off the myosin protein are these things that appear to be blue chicken legs. Are you following me? These are called myosin heads. Who's following this so far? And sitting on the myosin head, hold up, you're not going to believe this. Oh, this is a big one. Is a molecule of ATP. Tell me you're following me so far. Guys, now watch. In order to contract the muscle, the myosin head has to somehow bind to the actin molecule. And in this video, the actin molecule looks like a string of partially chewed beer nuts. Like somebody chewed on some beer nuts. Do you see that? Okay, here's the kicker. Here's the kicker. In order for the myosin head to bind to the actin molecule, there is a little licorice whip on the actin molecule that covers the binding sites for the myosin head. Are you following this? That licorice whip, in this case it looks like a blue and purple licorice whip. Wonder what that tastes like. That's called tropomyosin. What's the function of tropomyosin? It's to cover the binding sites on actin for the myosin head. Who's with me? All right. Now, watch. Do you see these little yellow things here that appear to be partially chewed banana bubblicious bubble gum? This, ladies and gentlemen, you better write this down. This is a big. This is called the troponin complex. And the troponin complex consists, you better get this, of 3 troponin molecules. Troponin I, troponin T, and troponin C. There may be a troponin me, because there's an I and a me in Timmy and no you. But there's a troponin T and troponin. There ain't no troponin me. Tell me you got that. Okay, now watch. Please get this right. Where does calcium come from in order for the heart muscle to contract? Where does the heart get its calcium to contract from? The blood. Say yes. These little red balls are calcium. Tell me you got that. So when calcium comes in through leak and voltage gated channels in heart muscle cells, we'll cover that, it floods into the actin and myosin filaments, say yes. And calcium is going to bind to one of these 3 troponin complexes. Which one do you think it is? And before you answer it, I'll give you a hint. So which one do you think it is? Troponin C. So watch. When calcium binds to troponin C on the tropomyosin molecule, it's going to cause the tropomyosin molecule to twist out of the way. And it's going to reveal those binding sites on actin for the myosin head. Do you follow that? There's going to be a natural attraction between the myosin head and that actin molecule once that site's revealed. Who's following this? So let's observe. Watch it. This is where you start the process. This is how you start your answer. Calcium from the blood floods into the actin and myosin filaments of a heart muscle cell. Who's following this? Who's with me? Watch. When calcium floods in from the blood through leak and voltage gated channels, calcium binds to troponin C on the troponin complex. Say yeah. When calcium from the blood binds to troponin C on the tropomyosin molecule, right? It's going to cause the tropomyosin molecule to twist out of the way. And it's going to open up that binding site on actin, the partially chewed beer nut, for the blue chicken leg. So watch. Bam. Now there's a connection between actin and myosin. What sits on the myosin head? ATP. Oh, crud TP. And when the myosin head binds to the actin molecule, ATP gets the third phosphate broken off, and it's broken down to ADP plus energy plus heat. And that energy is enough to swing that myosin head. And what's connected to the myosin head now? Actin. And when you're pulling actin, you're contracting. Like when this camper's a-rocking, don't come a-knocking. Did you ever see that? Yeah, okay. Tell me you followed that. Now watch. Watch. The number of connections between actin and myosin determines how hard the muscle contracts. So watch. If you flood in calcium, a ton of calcium, it can bind to more troponin complexes, right? Troponin C, are you with me? And that will cause more tropomyosin to twist out of the way and cause more myosin to bind to actin. Say yes. So this is how calcium determines the force of contraction of a muscle. The more calcium that's available to the heart muscle cell, the more connections you can make between actin and myosin. And the more connections you make, the stronger the contraction. Say yes. How many people followed that? So if somebody's heart is in really bad shape, you can actually give them IV calcium to improve the contraction of their heart muscle. Because where does the heart muscle get calcium from? The blood. Who's with me? All right. This is the most important piece right here. Watch. 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 In a normal, healthy heart, the actin and myosin are lined up like this. You have myosin, but no actin. You have actin, but no myosin. So where's the only place you can make connections between actin and myosin? Is where they overlap. Do you follow that? Now watch. In a normal heart, if you stretch the heart by adding more blood back to it, you line up the actin and myosin so you can make more connections between the actin and myosin. And when you do that, the heart muscle contracts harder and stronger. How many people follow that? That's Starling's law of the heart. How many people got that? There's a question about Starling's law of the heart. Never forget it. Looking at the time, good. Good, writing it down. Good. Good. That's Starling's law of the heart. What's that called? In a healthy heart muscle, if you stretch the heart, you line up the actin and myosin, you make more connections between actin and myosin, so the heart contracts harder. And when you, I want this, and when you increase the force of contraction of the heart, you do two things. You increase the amount of blood pumped per beat. And the amount of blood pumped per beat, anybody know what that is? That's very good. stroke volume, and you increase the systolic pressure that's generated. Who's following that? Yes? That's Starling's law of the heart. Are you ready? I need to go over this. If you know it and you heard it before, then you can update your Facebook status. I'm going to explain to you the circulation of blood through the heart. This is exactly how I wanted it explained. Exactly how I wanted it explained. Do you understand? Exactly how I wanted it. We know that all the veins of the body dump their venous blood into the right atrium. We know this, right? Guys? So all the venous blood from the upper body dumps into the right atrium through the superior vena cava. All the venous blood from the lower body dumps into the right atrium through the inferior vena cava. Say yes. At the exact same time that venous blood from the body is filling the right atria, oxygenated blood from the pulmonary veins is filling the left atria. And when the atria are filling with blood, they're under high pressure, and therefore the ventricles are under low pressure. So as venous blood from the body fills the right atrium and oxygenated blood from the pulmonary veins fills the left atria, you're going to hit a critical pressure. And that critical pressure is going to force open both the tricuspid on the right and mitral on the left. Say yes. Say yes. And how much blood goes from the atria into the ventricle simply by changes in pressure? 75% of that blood from the atria goes into the ventricle simply by changes in pressure alone. Then the other 25% of that blood goes into the ventricle when the atria what? Contract. What's that called? I didn't hear you. Atrial kick. Say yes. Can you live without your atria contracting?
Yeah.
For how long?
Until you die.
Oh yeah?
Old people do.
How many people watched this video? Did you? Maddie? You didn't?
Have you done what the
Maddie didn't watch the video and she got a attitude.
You don't even know.
Wait, an attitude while she's in class and eating stuff.
What was that one during the day of the test? The one that was.
If you get me out of here by 8, I won't like your whole life. Wow.
Yeah.
I didn't even see that. You did.
Yeah, both of you guys got it. I couldn't believe it.
Did people stay late?
Yeah, they answered that at like 8:20. So,
You didn't watch the
Okay.
sunlight from, did you?
well, yeah. Okay, who cares? Are you guys with me? Okay, tricuspid on the right, mitral on the left. Now, watch it. Now you got venous blood in the right ventricle, oxygenated blood in the left ventricle. Which ventricle contracts first, the right or the left? They contract at the same time. Do you want blood in the right ventricle going into the left atrium? No, it couldn't, unless there was some kind of really bad heart defect. You don't want that blood regurgitating back, right? So here we go. You better get this. Boom. So watch. You learn this in general, that the mitral valve and the tricuspid valve will close to prevent blood from regurgitating back into the right and left atria. Say yeah. If you look at the way they close, that is a very strong position, right? Also, the right and left ventricle have papillary muscles that are connected to chordae. So when the right and left ventricle contract, the right and left ventricle papillary muscles contract and tighten up those chordae and prevent those valves from flopping around. You don't want that. So in some people, though, the valve can be prolapsed. It can be inverted like this. And you have mitral valve prolapse. And then some of that blood can actually regurgitate back into the left atrium, and you get mitral valve regurgitation. Say yes. Do you want that? No. Did I show you that there's mitral valve support groups too? Did I show you that? Yeah. I didn't go over the circulation of blood through the heart, did I? Okay. If you watch the video, you're bored right now, and you're like, you're wasting my time, Tim. Am I? Michelle says I am. Yeah, fine. Be that way. Fine. I'll go very fast then, Michelle. You want this accelerated? Yeah. Okay, watch. When the right ventricle contracts, it's going to force open the pulmonic valve, and that blood is going to send through the pulmonary trunk, left and right pulmonary artery, pulmonary arterioles, and pulmonary capillaries. And every pulmonary capillary has associated with it an alveoli, and that's where gas exchange occurs. Say yes. At the exact same time, the left ventricle is going to contract, open up the aortic valve, and send oxygenated blood to the cells of the body. Say yes. That's the circulation of blood through the heart. I want the whole thing, and I want it explained as a unit. Tell me you got that. Okay, here we go. Any pressure in the veins? Maddie? How does venous blood get back to your heart if there's no pressure in the veins? One-way valves and muscle. What's the other way that gets back? The thoracic pump. You better know about that. I'm not going over that, Michelle. I refuse. Tamaya, do I have to go over the thoracic pump? Okay, fine. Be that way. Nobody cares. All right. Ready? Ready? Here we go. There's a couple of ways to increase venous return to the heart, right? Number one is exercising, right? When you exercise, you use your legs typically, right? And thereby contracting more muscle. And when you contract more muscle, right, you squish more veins. How do you spell squish? And when you squish more veins, that will increase venous return to the right side of the heart. Say yes. You can invert the person, right? Put them on their head. That way, by gravity, all that venous blood that was sequestered in your legs by gravity will now come back to the right side of the heart. The other thing is you can increase their blood volume. Tell me you got that. Regardless of how you do it, if you increase venous return of blood, now watch, and I want this whole thing explained. Whole thing. Everything right here explained. If you increase venous return of blood to the right side of the heart, what are you going to do to the right heart? You're going to stretch it. And when you stretch a normal heart, what do you do to the alignment of actin and myosin? Yeah, I guess that's right. You align actin and myosin, better. And if the alignment of actin and myosin is better, what happens to the number of connections between actin and myosin? That's right, connections. And if you increase the number of connections between actin and myosin, That leads to an increase in the force of contraction of the heart. And what does that do to the amount of blood pumped per beat and the pressure with which that blood is pumped? Right. It's going to increase their stroke volume, and it's going to increase their systolic blood pressure. Say yes. What you do on the right side of the heart, you will have to do on the left side of the heart. So all of that venous blood is going to go to the lungs. It's going to get oxygenated, and now more blood is going there because more blood pumped per beat, and the pressure is going to be higher. So all of that newly oxygenated blood is going to come back to the left heart. And what are you going to do to the left heart? Stretch it. The alignment of actin and myosin is going to be greater. So what's going to happen to the force of contraction, the amount of blood ejected with each beat, and the pressure with which that blood is ejected? It's going to go up. Say yes. That's Starling's law of the heart. You got me? And I'm going to say this real slow. When you write your answer, and any of your answers need to be explained using Starling's law, you're going to explain to me what happens on the right side of the heart and on the left. If you skip it, I'm marking it wrong. Do you understand? You're going to learn how to think in a process. I get to skip steps. Do you know why? Do you know why, Michelle? I got mine. And when you got yours, you can skip steps. Yeah, them Duke boys. They got my money. What? I think all of us are going to, all of you. Yeah, we're all going to fight.
No.
Did I tell you that I went to this meeting, right? Just real quick. And I said, look, when I give out a test, no student is allowed up. If they get up, I start throwing stuff at them, right? They know better. Sometimes I'll have like dirty scalpel blades, and I'll throw them at them. And one of the nurses, you're kidding me. I go,
What did you say to her?
huh?
What did you say back?
I go, what do you think? You don't think there would be some kind of scene, right? TMJ4, Instructor at Technical College throws scalpel blades at students for getting up. How many people got this? Say yes. Did I explain this to you? Did I explain to you when the guy came in, he got hit by the Ford truck? I explained that to you? Watch. When you explain that, you're going to explain it all the way. Say yes. And any time the left ventricle in a resting individual, you get an increase in systolic blood pressure. You get an increase in systolic blood pressure where? Everywhere, including anytime you increase systolic blood pressure, it will cause your blood pressure to go up, and you will make urine. That's pressure diuresis. Boom. Say yes. Okay, here we go.
Wait, so for that was like the question about the IV, like
Yeah.
But do you want the venous or the Starling's law in that answer?
It has to be to get
Okay.
full credit. Tell me you got that. Right? Okay, here we go. That's why I said I wasn't finished with that. Now I'm finished with that. How many people followed that? If you didn't, that's too bad. I'm moving on. Okay. Ready? I kind of lied to you in general, but it was for your own good. Now watch. Remember when I told you, and I'll never forget it, it was a Tuesday, definitely. Remember when I told you when the atria are full of blood, the ventricles are empty? Remember that? I lied to you about that. They're not empty. Sorry.
Sorry.
Watch. Do the ventricles, when they contract, squish out all the blood that's in them? No. Here we go. Ready? Watch. We're talking specifically about the left ventricle. It applies to the right ventricle, but in this case, we're just going to talk about the left ventricle. The left ventricle has a certain amount of blood in it before it contracts. What has to happen before systole? You have to end diastole. Whoops. So the end diastolic volume in the left ventricle is the amount of blood in the left ventricle before it contracts. Say yes. When the left ventricle contracts, it pushes out a certain amount of blood per beat. That blood that's ejected per beat is called stroke volume. And now you're left with a certain amount of blood in the left ventricle after it contracts. And that's called your end systolic volume. Now, normal end diastolic volume in a normal average adult heart is about 110 cc's. Normal stroke volume is about 70 cc's. So doing the math, 110 minus 70 equals 40. So your end systolic volume is 40 cc's. Tell me you got that. Now, one of the things that a doctor or cardiologist wants to look at is they want to look at the efficiency of the heart. How well that heart is contracting. Is something impairing the heart's ability to eject that blood? So when they look at a heart and they're looking at wall structure and volume, what they use is an echocardiogram. So an echo looks at volumes and the structure of the heart, valves and wall movement. So what the doctor wants to do is determine whether or not the heart, in particular the left ventricle, is functioning efficiently. So they look at this concept called ejection fraction. An ejection fraction is a measurement of the efficiency of the pumping mechanism of that left ventricle. And how you determine ejection fraction, and it's abbreviated EF. Now, I know what you want to do, and I'm going to put the kibosh on it right now. I wrote down just the abbreviations, EDV, ESV, SV. If you write EDV equals end diastolic volume, I'm marking your whole life wrong. Do you understand that? You're going to tell me what end diastolic volume means. Say yes. Right? So ejection fraction is a measurement of the efficiency of the pumping mechanism of the heart. And it's your stroke volume divided by your end diastolic volume. So in a normal heart, what's a normal stroke volume? 70 cc's. What's a normal end diastolic volume? 110 cc's. So you're going to get a fraction. You're going to get a fraction of about 65%. So anything over 50% is considered a normal functioning left ventricle. Anything under 50% is diagnostic criteria for congestive heart failure. Who's following me? Guys? All right. So watch. Watch. How many people, anybody on nurse's aid here? Okay. If somebody calls in sick, what do the rest of the aides have to do? They have to work harder, right? Because you still got to get these people up, fed, bathed, the whole 9 yards. So they have to work harder. So in congestive heart failure, what you're looking at, and one of the biggest ways to get it, is death of heart muscle. Death of heart muscle basically means that an aide called in sick. So what is the rest of the left ventricle going to have to do? It's going to work. You better, I'm going to say this real slow. The left ventricle works harder by stretching. The left ventricle works harder by stretching. wow, this is so true right now. So true. You have no idea how good this information is. No. Because no one will explain it to you like this. I shouldn't even explain it to you. Do you think you'll ever take care of a patient with congestive heart failure if you come in? I don't think so. Talk about the tell later. Now watch. Watch. This is a normal, healthy heart. You got me? If you add more blood back to it, you're going to stretch it. So what's going to happen to the force of contraction? The amount of blood that's ejected with each beat and the pressure with which that blood is ejected. Boom. Now watch. The most common part of the heart to be affected by congestive heart failure is the left ventricle. You got me? Where did the left ventricle get its blood from? Where did the left atria get its blood? What's the valve that separates the pulmonary veins from the left atria?
What did you say?
What's the valve that separates the left atria from the pulmonary veins? There isn't one. Correct. So watch. You need to get this. And I'm going to tell you right now, I see your future. I see it. And if you would only drink the freaking Kool-Aid now, okay, the price, your life would be so much better. You just won't. Because, can I just tell you this? And I thought about this coming in today. And I shouldn't even have to say this because you guys are adults. But if you could just suspend disbelief for a minute, and instead of trying to get a grade, try to actually learn this stuff, you would be amazed how easy it can be. You can't get that out of your head, though. You can't get past that. And I can't help you with that. You'll learn. Anyways, I digress. I gotta get through this. Because I see it. I just wish you would try. I wish you would try to get this stuff. What is it? Is it too much?
No.
Guys? What? You okay? Let me go. Here we go. What?
You
I mean, go out here.
Oh, why?
Can I just go?
Yeah.
Please?
Yeah, Facebook.
Alright, watch. That's a dead part of the heart. That don't work. So the rest of the heart has to work harder. And the rest of the heart works harder by stretching. At rest, in someone who has congestive heart failure due to myocardial infarct, at rest, this is as good as it gets. It doesn't get any better than this. Do you understand that? The best force of contraction of their left ventricle is when they're at rest. Do you understand that? Say yes.
Yeah.
How do you increase venous return of blood to the right side of the heart? What exercise? What else? You invert them. Say yes, right? Or you give them fluid, IV or look. Say yeah. Okay, here we go. What happens in a person with congestive heart failure is the left ventricle dilates. It becomes bigger. You got me? And now, because part of the heart is damaged, it doesn't contract as hard. The result is this. Instead of having 110 cc's sitting in that left ventricle is dilated. And now it has 210 cc's in it. So the end diastolic volume, or the amount of blood in the ventricle before it contracts in a person with congestive heart failure, goes up. do they still have to pump out 70 cc's? Yeah, they got to maintain Q, right? So how much is left in that left ventricle? Now your end systolic volume goes up to 140 cc's. What happens to their ejection fraction? Their ejection fraction is 270 over 210, so it's now 33%. So this heart is severely damaged. It is a dilated left ventricle. Tell me, you're with me? So with a person with congestive heart failure, can they drink as much fluid as they want? No, because if they drink fluid, that will increase their blood volume and that will increase venous return to the right side of the heart. Is the right side of the heart damaged? No. So the right side of the heart is going to stretch, increase the force of contraction, and the amount of blood ejected with each beat and the pressure with which that blood is ejected to the lungs is going to go up. All of that blood that was in the lungs will now come back to the left heart. The left heart at rest is as good as it gets. So if you add more blood back to it, you will overstretch it. Now it has more blood in it and it will contract more weakly. Say yes. Where did that blood come from? Where did it come from? It came from the left atria. Where did the left atria? Pulmonary veins. Where did the pulmonary veins get it? Pulmonary venules, pulmonary capillaries, and it will start pushing fluid into the alveoli, and you get pulmonary edema. No one will remember this by the time you need it in clinical. You just won't. That's too bad.
So
It's rock solid.
they put them on a low sodium diet too, right?
Yeah.
And I had a patient, she was freaking out because she couldn't eat
She can't eat.
what she wanted because it had so much sodium, and they said that your heart will literally fail. if
Well,
don't
you should have
follow
let
this
her
diet.
then. We have all the right. We have the right to kill ourselves in this country. You do, right? I want to eat sodium. Okay, this is what happens if you eat sodium. You're gonna retain volume. Your heart's gonna fail, and you're gonna die. Okay, I'll take my chances.
I have a question, so, is it like every time someone has an MI, they'll have congestive heart failure afterwards?
No, not always. Number one, it depends.
The amount.
It depends on the size of it. And there's different types of MIs, and I'm not going to go into it. But generally speaking, congestive heart failure is a syndrome.
Get it, is what I'm
Yeah.
saying, yeah, from part of the heart dying.
Yes. Over time, they will develop congestive heart failure. They will. So, if somebody's got congestive heart failure, do you want them getting up and walking around? A lot. Why?
Because then the venous return will come back.
That will increase venous return. How a doctor diagnoses the severity of CHF is the doctor will ask, how many pills do you sleep with? And if the person says 1, okay, then it ain't that bad. If it's 2, it's getting worse. Doc, I can't sleep in bed anymore. I have to sleep on a recliner with my legs down. That's to sequester all that venous blood in their legs so they can breathe, so they don't go into pulmonary edema. That's why they do that.
Oh my god, I had a patient literally yesterday that needed to sleep in a chair. She said.
Right. And no one will explain that to you. Watch. That's why nurses have to write care plans, because they don't know the pathophysiology of any disease. Okay, how many people got that? So I explained to you what happens to the changes when someone develops CHF. Say yeah. Okay? All right. Do you want to learn about diuretics and how they work or no? Yes or no? Very quickly. Diuretics make you pee more. So it lowers your blood volume. So diuretics affect, reduce preload. If you got a jacked up left ventricle, do you want to pump blood through arteries that are this big or this big? A or 2? A. So you give them arterial vasodilators. Learn more about that later. All right? And then what you want to do, so you want to reduce afterload. I'm defining afterload. Afterload is our systemic arterial resistance. So if you make the arteries bigger, there's less resistance, so you're reducing afterload. Say yes. So you want to reduce afterload in CHF, and you want to reduce preload in CHF. Do you want to make the heart contract harder? You don't? It's contracting weakly. Do you want it to contract harder? So you give them positive inotropic agents. Drugs that increase the force of contraction of the heart. Inotrope increase the force of contraction of the heart. Okay? A negative inotrope decreases the force of contraction of the heart. Okay, yeah. Then you got other drugs like chronotrope. Those, they affect heart rate. Got me? Do you want to learn how digitalis works? Do you? Yes or no? Digoxin, Lanoxin. You ever hear of that drug? Anybody heard of it? No? Yeah? There's a video on it. You look at that. That's congestive heart failure. Okay. Hang on. One second. You son of a- Come on. 1, done. 2, done. 3, done. 4, not done. 5, I did that, yes? 6, done. I did describe the circulation. I will do the electrical conduction system, and that will take us into 7. So I'm going to do parts A and C, and I'll come back to B. I did Ohm's flow law, yes? Explain Starling's law of the heart, explain how that principle applies to CHF, done. 12, cardiac output. Cardiac output is heart rate times stroke volume. Just write that down. Explain how cardiac muscle contracts, boom. I will do that. 14 I will do. 15 I did. 16, did I do that?
I thought that was the one you said I'm not done with it yet.
Okay, then I'll put a I'll put a squiggly check there. 17, I can do that. 18 I will do, right? So I didn't do. And 19. So watch. I'm going to explain. I'm going to tell you exactly how I'm going to do this. I'm going to explain now the electrical conduction system through the heart. So I'm going to do 6A. Say yes. That's going to take us into 7. A and B. You got me? 7A and B is worth 450 points. It's going to be on there, just so you know. You got me? Can I be any clearer than this? And then I'm going to explain 19 as I explain parts 7A and B. Say yes. Here we go. The heart is unique. The heart has two. The heart has two specialized cell structures that are found in no other cells of the body. They have gap junctions, and these gap junctions allow electrolytes to instantly spread from one heart cell to the other. So electrically, even though the atria are made of millions and millions of individual cells, they electrically function as one huge atrial cell. They also have intercalated discs, and intercalated discs connect mechanically all the atrial and ventricular cells. So when the electrical impulse travels instantly over the atria, they contract as a unit. So intercalated discs and gap junctions allow the atria and ventricles to function as a unit. The other thing is that the heart has specialized heart cells that don't contract, but rather generate electrical impulses. They produce electrical impulses. If you rip somebody's heart out of their chest, it will beat on its own. The heart does not need nerves from the brain and spinal cord to cause it to contract like skeletal muscle do. That's because it has its own natural intrinsic rate called the electrical conduction system of the heart. Now, in the electrical conduction system, there are three potential pacemakers of the heart. The primary pacemaker is the sinoatrial node, or SA node, and its natural intrinsic rate is 60 to 80 beats per minute. So that's why the normal heart rate at rest, with no other influence, is between 60 and 80 beats per minute. The next potential pacemaker is the AV node, and the AV node has an intrinsic rate of 40 to 60 beats per minute. And then finally, you have the Purkinje fibers. And the Purkinje fibers, they have an intrinsic rate of 15 to 30. Now, there are some heart conditions that will cause failure of the SA node to fire. And if the SA node doesn't fire, then the AV node takes over as the pacemaker. The result is a drop in heart rate. But you can still do okay with a heart rate of 40 to 60. You're not going to leap tall buildings. Anyways, if the SA node and AV node fail, then you're left with the Purkinje fibers as a pacemaker. And with that, you can't live very well with a heart rate of 15 to 30. So you need a permanent pacemaker. So what they will do is they will put a pacer into the infraclavicular fossa, and they will run pacer wires through the subclavian vein, inferior vena cava, right atria, and then the right ventricle. And because of gap junctions and intercalated discs, the electrical activity that's produced by these pacer wires will be transferred over to the left side of the heart. So you don't need to pace the left side. You just need to pace the right atria and right ventricle. Say yeah. There's a condition called Twiddler syndrome where people will actually turn the pacemaker underneath their skin, pull out the pacer wires, and then they'll start getting dizzy or lightheaded. They're not sure why. Okay, so let's start with the sinoatrial node. First of all, a couple of things about the anatomy of the heart, and you need to know this. You always want the atria to contract before the ventricle, right, to allow for that atrial kick. So separating the atria from the ventricle is this fibrous non-electrical conducting ring, this electrical insulator that electrically insulates the atria from the ventricles. The connection point between the atria and the ventricles is then the AV node. So let me explain. First of all, when the SA node fires, and it naturally fires at an intrinsic rate of 60 to 80 times per minute, it's going to send an electrical impulse over both the right and left atria. Why? Because of gap junctions and intercalated discs. And if you have a monitor hooked up to somebody, what you're going to see is this. And this is the P wave. And the P wave represents the electrical activity spreading through both atria. And in your book, it's called atrial depolarization. That's a fancy way of saying depolarization. That represents, and that's represented by the P wave. Now, because of the fibrous non-electrical conducting ring, these electrical impulses are prevented from going directly to the ventricle. And you don't want that to happen. You don't want the atrium and the ventricle to contract at the same time. Otherwise, you lose atrial kick. So what happens is all of these electrical impulses that are generated by the sinoatrial node, they can't get to the ventricles directly, so they are funneled into the next portion of the electrical conduction system called the AV node. And in the AV node, there's an electrical delay. The impulse actually sits there for a minute to allow the atria to contract and push that additional blood into the ventricle. Then that impulse will travel through the next portion of the conduction system, which is called the bundle of His. In your book, it is called the AV bundle, the bundle of His. And then the bundle of His branches, hang on, into the left bundle branch and the right bundle branch. And as you can see, the left and right bundle branch further bifurcate into the Purkinje fibers. Now this is important. When the electrical impulse travels through the bundle of His, the left and right bundle at the same time, and then the Purkinje fibers of both the right and left ventricle, it will produce on the EKG the QRS complex. And the QRS complex represents ventricular depolarization. Ventricular depolarization represents the electrical impulses traveling through the bundle of His, the left and right bundle branch, and then the Purkinje fibers of both the right and left ventricle. Now, what you want is, hang on. So let me do this. So let me label that too. Oh, come on. This is the QRS. And again, the QRS complex represents the electrical activity going through the bundle of His, the left and right bundle branch, and then finally the Purkinje fibers of both the right and left ventricle. And that's going to cause the right and left ventricle to contract at the same time. Now your hope is that the electrolytes that produce this electrical activity are going to reset themselves, and that you're going to have more than one heartbeat today. And the resetting of the electrolytes in the ventricles is shown by the T wave. So the T wave represents ventricular repolarization. So it's the resetting of the electrolytes in the ventricles. The reason you don't see the atria resetting is because ventricular depolarization occurs at the same time as atrial repolarization. So the QRS masks the repolarization of the atria, so it's not shown on a normal EKG. Tell me you got that. That's that. Okay, now this is going to get a little bit dicey. Hang on a second. Okay. All right. So what I'm going to try to explain to you is how the electrolytes actually move in heart cells in order to produce that electrical activity. So a couple of things you're going to have to know. Where is it? Here it is. This is called the cardiac action potential. And that's in your book. So how I ask the question is, explain how cardiac muscle is able to generate and sustain its electrical activity. That's the same thing as saying, where is it? Cardiac action potential. Got me? All right. This is 450 big ones. This 7 and A and B, 400. It's going to be on there, just so you know. So let me define a few terms. Number 1. That membrane. Resting membrane potential. Resting membrane potential equals the charge inside heart cells when they ain't doing nothing. So your heart contracts and relaxes, right? So when it ain't doing anything, when it ain't contracting, it's relaxing. And when it's relaxing, there is a charge inside those heart cells. That charge inside heart cells, when it ain't doing nothing, is called the RMP, or resting membrane potential. You got me? All right. Now, in order for a heart cell to produce a particular electrical activity, right, to produce an action potential, to depolarize, that resting membrane potential has to reach a critical voltage. Now, remember, and I'll never forget it, on quiz number 1, I asked you to explain 7 ways that stuff moves into and out of the cell. Do you remember that? I'll never forget it. And I said that leak channels, the sodium potassium pump, and voltage gated channels had to be 3 of those ways. Do you remember that? This is where it's going to come back to you. It ain't going to bite you. It ain't going to do it. It's just going to come back to you. Tell me you got that. So when you reach a critical voltage inside that cell, that critical voltage is called threshold. And at threshold, you activate voltage gated channels. And if you recall, voltage gated channels are kind of like opening up the floodgates, right? Leak channels leak in. Voltage gated channels, you flood them in. Say yeah. Okay? All right. So what I'm going to do is I'm going to show you. And I'm going to kind of blow this up. Ready? I'm going to take a cell of the SA node and I'm going to blow it up. You got me? So what I'm telling you is I'm going to do this, right? 2 curved lines in a circle, and this is going to be an SA node cell. You follow? All right. So I'm going to explain to you how these electrolytes move, and then the consequences of them moving too much, or I forgot to hit it. Oh.
Let's see. That'd be
Yeah, that would be.
forgot what?
No, I didn't.
You forgot to record.
I didn't. Okay. So are you ready? Is everybody familiar with our starting point here? We're going to be looking at a cell of the SA node, right? So watch. This is the cell membrane of the SA node. You got me? That's the blood. So there are 3 electrolytes that go into creating the electrical activity of the heart: sodium, calcium, and potassium. And as we know, sodium and calcium highly concentrated in the blood, and the only way that they can leak in is through a specific sodium and specific calcium ion leak channel. Potassium's being highly concentrated in a cell, and it can only go through a potassium ion channel, right? Here's the kicker. Potassium is 100 times more permeable than sodium or calcium. So that means that for every 1 sodium and 1 calcium that leaks in, 100 potassiums leak out. The result is that the outside of the SA node cell becomes positive relative to the inside. Now, anytime you have a difference in charge across the cell membrane, if that cell has voltage-gated channels in it, it can produce electricity. And since we're talking about voltage, obviously the heart has voltage-gated channels in it too. Say yes. So the other thing that goes into maintaining and then reestablishing the resting membrane potential is our buddy, our pal, the sodium-potassium pumperoni. And it will pump out 3 sodiums that leaked in and 2 potassiums that leaked out, and that requires ATP. So the sodium-potassium pump is involved in maintaining this resting membrane potential, and then once the heart has fired, helping reestablish it. And that, of course, requires ATP. Now, I don't care about numbers and about the charge, the voltage inside the heart cell. It doesn't matter to me. What I want you to do is be able to understand this concept, because this has huge clinical import. All right? So here we go. Now, you need to write this down, because this is how you're going to explain your answer. Remember that when you rip out somebody's heart, it will beat on its own. The heart does not need nerves to stimulate it to fire. That's because the electrical conduction system of the heart is inherently, naturally leaky to sodium and calcium. And as you can see, sodium and calcium are positive. What's the charge inside the cell? It's negative. So when sodium and calcium begin to leak in, potassium stops leaking out. So once you hit this critical voltage, this resting membrane potential, potassium stops leaking out, and sodium and calcium begin to leak in. And because they're positive, they're going to raise the resting membrane potential. It's going to become more positive. Say yes. You're following this a little bit. Okay? All right, I'm not even going to look. All right, let's do this. Let me erase this here. Okay, now watch. You're at resting, it's negative. What begins to leak in? Sodium and calcium. And when enough sodium and calcium leak in, it's going to hit that critical voltage called threshold. And at threshold, what's activated? I'll just tell you. Voltage-gated channels. And the 2 voltage-gated channels that open up, and I'm telling you they occur at the same time, even though they don't for simplicity. I'm telling you that when enough sodium and calcium leak in, it activates voltage-gated channels. And that's going to open up sodium voltage gated channels and calcium voltage gated channels. So sodium is going to pour in. And because sodium is positive, the charge inside that heart cell is going to become rapidly more positive. And when it becomes rapidly more positive, that's called depolarization. Say yes. So what causes depolarization of the heart? Sodium flooding in. Say yes. What's the most important element in muscular contraction? Oh, don't even answer it. I'll answer it. Calcium. Where does the heart get its calcium from? The blood. How does calcium come in? Through voltage-gated calcium channels. Wee-hee. Yeah. You see that? Boom. The heart is now depolarized. It has fired. Now you're going to hit another critical voltage right here. At this critical voltage, the voltage-gated sodium channels close. So they open quickly and they close quickly. The voltage-gated calcium channel remains open. So calcium begins to flood in still to contract your heart muscle. But the voltage-gated potassium channel is now open. So what do you got? You got a positive thing coming in and a positive thing leaving. The positive thing leaving, potassium leaving, leaves faster than the calcium enters. So there's a slow downward shift of the charge inside that heart cell. You got me? Then you're going to hit another critical voltage. Lots of critical voltages. And at that critical voltage, at that critical voltage, the voltage-gated calcium channels close, but the voltage-gated potassium channel remains open. So potassium begins to flood out. And because potassium's positive, the charge inside that heart cell is now going to become more negative because the positive thing is rushing out. So, and the voltage-gated potassium channels remain open even to the point of being lower than the resting membrane potential. This is called hyperpolarization. In your book, they call it overshoot. You got me? And I'll explain why that's important in a minute. Just know that it happens. So now the charge inside that cell, that heart cell, is actually more negative than resting. And the voltage-gated potassium channels, right? They close right here. So right here is where the voltage-gated potassium channels close. Right? So no more negative stuff can come out. And then it's the job of the sodium-potassium pump to bring it back to resting. Then, once you're at resting, sodium and calcium leak in. Leaky, leaky, leaky. Boom. Leaky, leaky, leaky. Boom. And that's how the heart is able to produce and then generate and sustain its electrical activity. Say yeah. Just so you know, I want that whole thing. Say yes. Okay, hang on. Now watch. Watch. Okay, this is how they teach you how to remember the signs and symptoms of hyperkalemia, murder. Okay, write that down. Oh, yeah, look. Rhythm changes. Tall peak T waves. Widen QRS. Okay? Do you want to remember that?
Yeah.
Do you? No? I could explain it to you. You just want to remember it? Say yes. That way I don't have to explain it. Alright. So wait. I explained the cardiac action potential, did I not? I explained the EKG, did I not? Did I?
Yes.
Yeah, I did. Okay, watch. We're not done. I get there. I promise I'll get there. Okay, explain this EKG. I explained it. Yes? Explain what's occurring at each point. I explained that. Explain the EKG changes that would be observed if a patient's potassium was high or low. Okay? All right. Now, watch. And I know this is a lot to digest. That's okay, though. Right. You got time. You got till what? Next Friday or next Wednesday? What's that? I'll have this done by Wednesday.
I know you went over it.
Okay, so watch. Watch. I'm just going to tell you. Repolarization of the ventricles occurs due to potassium leaving. So where would you see potassium changes on an EKG? The what? The T wave, because where do you see the ventricles repolarizing? The T wave. Say yeah. So I'm not going to explain it to you. You just have to just remember this. Okay, so watch. All right, so P wave. That's atrial depolarization. Then you got the QRS. That's ventricular depolarization. And then you have the T wave, which represents ventricular repolarization. Why don't you see the atria repolarizing? Because the ventricular depolarization is occurring at the same time the atria are repolarizing, so they're masking it. So the T wave is ventricular repolarization. And that is the result of potassium leaving through a voltage-gated potassium channel. So you see repolarization on EKG for potassium in the T wave. So the first EKG change that you're going to see if someone's potassium level is high or low is on the T wave. And how you remember it is this. The T waves will become tall and tented in someone with hyperkalemia because you are piling up potassium. You got me? If your potassium level is low, then the T wave becomes prolonged and smushed because you have less potassium. You got me? And potassium slows depolarization, so your heart rate drops, and the QRS complex gets wider. Tell me you got that. So that's how they kill people. they inject potassium into the IV, their blood levels of potassium get high and their heart stops. So if it gets too high, your heart stops. So hyperkalemia, hypokalemia. The only way to get rid of potassium is to pump it out of the blood. So if your potassium level is high, they're going to recommend that you give them insulin and glucose, because you learned that insulin stimulates the sodium-potassium pump and drives the potassium into the cell. So that's the treatment that you would expect to receive from the doctor. Okay, go ahead, take a little break. Turn in your multiple guess. If you have any questions, come before class and I'll be glad to discuss them with you. But we're doing actually pretty good. So we can have that quiz as, let me see, today. We could really do it on the 28th. Yeah? Because we'll finish this up by Wednesday. We don't have that much more to do. You got me?
You want to tell us some that are going to be on
What's it?
Well, it's 7 for
there?
sure.
Some that are going to be on there?
Yeah, 7's going to be on there.
Didn't you say 2 for sure? And then the one about the DVTs for sure?
Yeah, 2 for sure. Yeah, and 5. Yeah, 6 will be on there. 8.
This is going to be a long quiz.
Yeah, it will be.
It's stressful.
That's okay.
It's like so stressful when it's there.
It's okay. Do you know why?
Right for a day, and then you're like,
Do you know why?
Is it okay?
Because you can drop one.
I know, but
Doesn't
you
matter,
still
I don't want to
do
grade.
bad.
What if
I don't like doing
really
bad.
like one of them I just need?
Well, you got to study.
Well, yeah, I know. That's what I'm saying. We're all saying we have to study.
Oh.
So 2, 5, 6, 7, 8.
11. 12.
You just have to force yourself to like this stuff, and then
15.
you'll do good.
Yeah, a lot of ones that have ADHD.
15 was the car, right?
See, 15 is
15,
cool.
yeah, is the car.
Ford Emblem.
Yep. And then
Starling's Lawn.
19's going to be on there because it relates to everything.
What about fetal circulation?
Yeah, fetal circulation, we got to go over that.
That's
That's a
cool.
big
Baby.
I have a video on that.
That'll be on there?
I don't know, I haven't decided. Okay, go ahead, take a break, and then turn in your multiple guess. All right, just put them right here. Put them right on the cards. Right on the cards. You got me?
Wait, what is even?
See, I can explain. I can explain these signs and symptoms that people get, these EKG changes that people get, without having to remember them. Right? Like, just like if you know epinephrine produces the signs and symptoms of hypoglycemia, you will never have to again remember the signs because you know what epinephrine does. See, that's what I'm trying to do.
34 years of doing music.
Like that.
No.
When you start like
She tagged me in
I
the
saw
pic.
them.
Oh, that's funny. So tin.
But see, here's the thing. Like, I knew after graduating with my bachelor's degree that I didn't know enough and that I was going to kill people. That's why I went and I got my graduate degree. And again, I'll just say this and I'm moving on. I wanted to learn it. And when I wanted to learn it, it came so easy.
How old were you when you like graduated? Like, done with school?
I was 28.
Oh, God.
Yeah, that's really not a big deal.
That's a lot of years to come home.
Yeah, I know.
He's just so chill about everything.
I know,
Like,
yeah.
you could say,
Yep.
yeah, I know. It's not a big deal.
Minus the phone, that's what it is.
What?
Nothing, we're talking.
But the stuff that I'm explaining to you, I learned, what, how old am I? 56. That's 28 years ago I learned this stuff. Right? And I never forgot it. Do you know why?
'Cause you
I
wanted to-
learned it. Cut it out. Okay. Watch. How many people want to buy a house? How many people own a house right now? Do you own it? Or the bank owns it? You own it? Yeah. Right? So, watch. Watch.
Do you really?
You buy a house for $150,000. You got me? And you have a $50 down payment. It's going to take you a long time to pay off that house, right? So watch. If your blood level of potassium is low, it's going to take you longer to reach that potassium equilibrium. Do you follow? So repolarization takes longer. That's why the T wave is flattened and prolonged. Now, someplace. Now, somebody, you win the lottery, right? No, not the big one, but. And you put $50,000 on the house. It's going to take you less time to pay off that house, right? That's why the T wave becomes tall and tented, because repolarization happens quicker. Say yes. Okay, I'm going to say one more thing and then I'm going to move on. If you write this down and you tattoo this, you'll never have to remember this. High levels of potassium in the blood, hyperkalemia, inactivate sodium leak and voltage gated channels. Inactivate sodium leak and voltage gated channels. What has to leak in for it to reach threshold? Sodium and calcium. Say yes. So if your blood level of potassium is high, what's not going to contribute as much to the leaking? Sodium. So what's going to happen to how long it takes to reach threshold? Longer. And the longer it takes to reach threshold, the longer it takes your heart to fire. So your heart rate is going to drop. What causes depolarization of the heart primarily? Depolarization. The opening of sodium voltage gated channels. If your potassium is high, what happens to sodium voltage gated channels? So does it take the heart longer to depolarize or shorter? It takes longer because less sodium is flooding in. So where do you see depolarization on an EKG of the ventricles? Depolarization. No, I'm circling it. The QRS, right? So instead of the QRS being real snappy, the QRS is widened because depolarization occurs by sodium rushing in. If it takes longer for sodium to rush in, depolarization is going to take longer. Do you follow that? No?
Yeah.
Just remember the tall tented T waves. So what's going to happen on EKG? This is your EKG, and then your kidneys start to fail. Okay. P waves gets lumpy. The QRS starts to widen, and the T wave becomes tall and tented. You got me? And then as potassium starts climbing, if your potassium level is 7, you lose your P wave, the QRS becomes wider, and the T wave becomes frickin' really tall and tented. Then when you get to potassium levels about 8, your heart, your ventricles kind of contract like, right? They barely pump. And then when your potassium level gets about 9, you go asystole. That's how you kill somebody. You give them potassium, and it jacks with their electrical conduction system. Did you follow that? A little bit? Watch.
So if it's low, the doctors will just order like IV potassium.
If it's low, you give them potassium. You give them kalemia,
High.
potassium. I hate me too. Okay, wait. If it's high, then you have to lower the blood levels of potassium, so you cram it into the cell. What stimulates the sodium potassium pump and will take that extra potassium and drive it into the cell? Say yes. That's why I made sure that you wrote down that insulin stimulates this. See, I have a plan for your life, Sheila. Believe it or not, everything I do in this class and I go over, there's a reason I'm going over it. Do you understand that? Like, I may not know what I'm look like I'm doing, and because I really don't. But the tall tented T wave right there, the QRS starts to widen. Then you lose the P wave and it gets real wide, and then you go asystole. Tell me you got that. That's really important that you understand that. If you remember, you know what? I'm going to give you extra credit. Not much. Ready? If you write that potassium inactivates, blocks sodium leak and voltage gated channels, I'll give you extra credit. Now here's the thing, listen up, cause this is true. Later in the semester we're going to talk about the nervous system, and I'm never going to bring that up, but if you remember that, then you'll be able to predict what will happen to the nervous system if your potassium level goes up. Say yeah. How many people got that?
Yeah.
Okay, here we go. All right, here's some clinical impact to what last night I go over to my kid's house. I'm working on his basement just real quick, and I see him up stairs in his kitchen doing his homework, and he's not reading the chapter. He's got like a worksheet, so he's looking in the index for like keywords, and I'm thinking I could take a picture of him and superimpose any one of your faces on it, and that's you. Am I about right?
If I like sit there and read it word for word, I will fall asleep. No matter how much coffee I drink before that.
If what?
Reading makes me fall asleep.
It makes everybody tired.
You can't read, so I just look for the terms. You read about the terms. I read too many.
But like, can I just ask you something? Like, you guys had to believe that this class was gonna be a lot of work, right? You just had to believe that, right? Like, there's no way you get around advanced anatomy and physics. Like, oh my God, this is gonna be the hardest class I ever took in my life. This is going to be the most information I've ever had thrown at me in one class. Like, you had to believe that, right? So you're not shocked coming into this class saying, okay, look, I knew what I was in for, right?
It's a lot. But I knew that, yeah.
You had to know that. Right? So I don't feel bad. All right, that's all I'm going to say about it. You got me? Okay. What was I going to tell you? Oh, this one I'm going to tell you. Ready? Watch.
Are you recording?
I don't know. Yes. Is that moving? Yeah. Okay. Watch. What has to leak in order for the SA node to reach threshold? I'm going to circle it, and then you just say it.
Sodium and calcium.
That's very good. What's the most important element in muscular contraction? Calcium. Where does the heart get its calcium from to contract? Okay, so watch. If you give somebody a calcium channel blocker, I'm really blocking that calcium channel, darn it. What's the only thing that's contributing to the rise in the resting membrane potential closer to threshold? Sodium. So now think, will it take longer to reach threshold or shorter? So what will happen to the person's heart rate if you give them a calcium channel blocker? It will what? It will slow down. That's why calcium channel blockers can be used to treat fast heart rhythms. No? Tell me you got that. You've heard of ventricular tachycardia, haven't you? Ventricular tachycardia, watch. 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 It looks like this. Say yeah. Are the ventricles depolarizing too fast or too slow? Good. What caused them to depolarize? What'd you say? Sodium. Have you ever heard of a drug called lidocaine? Have you ever heard of a drug called lidocaine? Guess what lidocaine blocks? And I'll give you $1.
Sodium.
Sodium what? And? So what happens to how fast they depolarize if you block them? It slows it down, so it slows their...
Heart rate.
Did you follow that? No, you did. Okay. Tell me you got that. That is the cardiac action potential. I want that whole thing. It's going to be on there. Do you understand? Yes or no?
Yes.
Okay. Okay. Get this right. You need to learn these terms. You just have to learn them. No one's going to talk like me in nursing. They're going to use all the big words. Because when you use big words, people think you're smart. They do. Okay, watch. Watch. What is that? B, that's good. That's beta adrenergic agonist. If you're an agonist, what do you do? You stimulate. Tell me you got it. If you're an antagonist, what do you do? You block. So an agonist stimulates, an antagonist blocks. Say yes.
Yes.
Are you with me?
Yes.
Okay. What are the two divisions of the autonomic nerve? You better get this. That's very good. What's the neurotransmitter for sympathetic stimulation, Tia? Norepinephrine. What's the neurotransmitter for parasympathetic stimulation? Acetylcholine. That was good. How did you know that? Don't give me that.
That's all I know.
Okay. If it releases norepinephrine, that nerve is an adrenergic fiber. If it releases norepi. If it releases acetylcholine, it's cholinergic. Say yes. What does the sympathetic nervous sympathetic and parasympathetic nervous system do? How do they function? If the sympathetic nervous system increases your heart rate, what does the parasympathetic nerve do? It decreases it. Say yes. Okay, here we go. I want this whole thing. Whole thing. If I don't get it, there will be trouble. Under sympathetic stimulation, when a sympathetic nerve is stimulated, it is going to cause the release of norepinephrine. Norepinephrine, when it gets released through the process of exocytosis, floats through the synaptic trough. Oh yeah, I'm using big terms today. And norepinephrine binds to norepinephrine receptors on myocardial cell membrane. See how the nice drawing is? The inside of this cardiac cell looks like a mountaintop. Anybody? That sign says, "Dem Duke boys got my money." All right, I want this. Another name for a norepinephrine receptor in a heart muscle cell is called a beta 1 receptor. What binds to beta 1 receptors? And norepinephrine. Norepinephrine's a neurotransmitter. Epinephrine is the hormone. Say yes to Maya. She's not saying anything. You got a headache, don't you? You want a drink of my Diet Mountain Dew? You want a marker? All right, fine, be that way. Okay, listen up because this is true. What's the most important element in muscular contraction? What causes depolarization of heart cells? That's very good. So when norepinephrine binds to norepinephrine receptors called beta 1 receptors, it will cause increased leakiness of sodium and calcium into the heart muscle cell. If sodium and calcium increase leakiness, I don't care. If sodium and calcium start leaking in more, what's going to happen to the time it takes to reach threshold? Will it be faster or slower? Faster. So what will happen to heart rate? Go up. What's the most important element in muscular contraction? So if more calcium leaks in, what will happen to the force of contraction, the number of connections between actin and myosin? Say yes. That's how the sympathetic nervous system affects heart rate and force of contraction, by making cells more leaky to sodium and calcium. Say yes. So, watch it. Watch it. Who's watching? Anybody? Nobody. Well, I don't care. Do you always have a little epinephrine and a little sympathetic stimulation? Yes, you do. So, if you were to give somebody, a medicine that blocked beta 1 receptors in the heart, that would be a beta adrenergic antagonist, better known as a beta blocker. What will happen to the heart rate? Why will it decrease? Why will it decrease? There's less sodium and calcium leaking in, so it will take longer to reach threshold. And if there's less calcium leaking in, what will happen to the force of contraction? So what will happen to the person's blood pressure? Go down. Watch it. So beta blockers are a negative inotropic and negative chronotropic agent. They reduce heart rate and force of contraction, and therefore blood pressure. How many people followed that? Yeah. Yes or no? Okay. Okay, watch. If you get this right, I'm going to be so proud of you. Celeste, I know you will get this right. So I'm not even going to offer you a swig off my Diet Mountain Dew, because you're going to get this right. When your blood sugar is low, what does epinephrine bind to in the liver to make your blood sugar go up? What? Did you say beta 3 receptors? Who said beta 3 receptors? Well, you're in trouble now. What does epinephrine bind to make your blood sugar go up? I'm going to change your grade. Beta 3. I know. You know what? Why do I got to be different? I shouldn't be. Just remember it, right? Do you want me to? Do you want me? Forget it. No, you know why? Because it's too much. It's too much. You're not relating this stuff. It's too much information. I know that. You got me? It's too much information. I'm just going to tell you this. If you're a type 1 diabetic, they use very judiciously beta blockers. Because if you give somebody a high-dose beta blocker, it will mask the signs and symptoms of hypoglycemia, and they can wake up dead. And I'll just leave it at that. I told you that. Okay, that's sympathetic. What's the opposite of sympathetic? Parasympathetic. That's right, parasympathetic. What's a neurotransmitter for parasympathetic stimulation? I'll just tell you, it's acetylcholine. What can cause parasympathetic stimulation to the heart? Strong emotional events. Let me give you an example. At the end of the semester, April 22nd, you may log on to WebAdvisor, look at your final grade, and look, and have strong emotional event to it. And that can stimulate the parasympathetic nervous system. When the parasympathetic nervous system is stimulated, it will release acetylcholine. When acetylcholine binds to acetylcholine receptors on the heart, it causes potassium to be more permeable. This lowers the resting membrane potential, and when you lower the resting membrane potential, it takes longer for sodium and calcium to leak in, so your heart rate drops. The parasympathetic nervous system doesn't do anything to the force of contraction of the heart. It decreases your heart rate. Okay? If you remember, cardiac output is heart rate times stroke volume. If you decrease your heart rate and your stroke volume stays the same, your cardiac output drops. Therefore, you drop. Say yeah. So in that case, what they do is if somebody passes out, they give them smelling salts. Smelling salts stimulate the sympathetic nervous system. What does the sympathetic nervous system do? It increases your heart rate. Or you can lift their legs up. And when you lift their legs up, you get increased venous return to the right side of the heart. And when you stretch the right side of the heart, it initiates the Bainbridge reflex. And you get reflex tachycardia. Your heart rate goes up. That's called the Bainbridge reflex. See, yeah. Okay. Sympathetic, parasympathetic. All right. Here we go. I'm answering part B of 7. Okay, here we go. In order for the heart rate to fire, one of the pacemakers has to reach threshold. The SA node has the resting membrane potential that's closest to threshold. That's why it is the pacemaker of the heart. So if the SA node fails, the AV node has a lower resting membrane potential, so it'll take more sodium and calcium to leak in. If that fails, the Purkinje fibers have the lowest, so it'll take much more sodium and calcium to leak in. That's why the heart rate drops. So the SA node has a resting membrane potential that is closest to threshold. There you have it. Okay. Boom, boom, boom. All right. Okay, number 14. I'm going to answer number 14 and number 17 all together. We will have quiz, cardiovascular quiz, Wednesday the 28th. I will get this done. All right, watch. Oh, hang on.
You cannot now.
What's that?
I know.
That'd be so bad. I just emailed you anyway.
About what?
Post a video.
Posted.
Oh. Yeah, I'll do that tonight. Okay, I will, I promise. I'm going to get home. I'm not even going to take a leak or anything.
Posted it already.
Yeah. And I'll post it. Okay. Did I tell you this class would get smaller? It's going to get a lot smaller. There'll probably be -1 student in this class. Here we go.
Yeah, Tim, don't doubt us.
I'm not doubting you.
Okay.
I'm doubting me. Here we go. This is an artery. do you know how it says artery? It says lumen of the artery. Okay? The artery is made of thick muscular walls, and it has, watch it, beta 1 receptors, and it has, I always have a hard time with this, alpha 1 receptors. You got me? I'm going to do this really quick. At basal levels of basal levels of epinephrine. That means epinephrine levels that you have right now. Right? Epinephrine binds to beta 1 receptors. And when epinephrine at basal levels binds to beta 1 receptors, it causes arterial vasodilation. You got me? Okay, I'm going to say this again, and this one's going to be on there. And I'm going to say this. This one's going to be on there. And I'm telling you, and I'm writing this down, and I'm going to say it again. At basal levels of epinephrine, epinephrine binds to beta 1 receptors and causes arterial vasodilation. If we learn, and we did, Ohm's flow law, that Q equals systolic blood pressure over resistance. If the arteries dilate under the effects of basal levels of epinephrine, the arteries dilate. What happens to resistance to blood flow? So what happens to your systolic blood pressure? It goes down. Okay? Tell me you got that. Now, let's look. That's at basal levels, right? Normal levels of epinephrine. At scared levels of epinephrine, high levels of epinephrine, high levels of epinephrine, high levels of epinephrine, epinephrine binds more to alpha 1 receptors. So high levels of scared levels of epinephrine. Epi selectively binds to alpha, I'm going to spell it out too, 1 receptors. And you have alpha 1 receptors literally on every artery of your body. So, and when epinephrine binds the alpha 1 receptors, it causes massive arterial vasoconstriction. Where? Everywhere. And according to Ohm's flow law, if all of your arteries massively constrict, oh, that's barely a hole. You got me? The resistance to blood flow is going to go way up, so your systolic blood pressure is going to go way up. Say yes. Why does it make sense that that happens? Because under the effects of high levels of epinephrine, we just learned that your heart rate will increase, force of contraction will increase because more sodium and calcium are leaking into the heart muscle cell, and the arteries will cause massive vasoconstriction of all of your arteries throughout your body. Why do you want that to happen? That's because you're preparing your cardiovascular system in your body to run or fight. Correct? Now, watch. Oh, I didn't do that right. So, when you start running and fighting, where are you metabolically active? In your legs and arms. And that will start producing ADP, heat, CO2, hydrogen ions, and they will initially be lacking oxygen because all of those arteries are going to be under the effects of epinephrine. Say yes. Good. So these will start, these cells, the metabolically active cells, will begin to produce byproducts of metabolism, which will cause all of the arteries that supply the most metabolically active parts of your body to dilate. But, this is the important piece, all of the non-essential parts of your body that go into running or fighting for your life will be under the massive vasoconstricting effects of epinephrine binding to alpha-1. Say yes, alpha-1 receptors. Say yes. So that guarantees that when you're running and fighting for your life, every bit of available oxygenated blood is going to your arms and legs for you to run or fight for your life. That's why it makes sense. There's a drug out there called Hitrin. Tia, you ever hear of it? Apresyline? Apresyline? No? All right, forget it. Okay. Did that. Watch it. Watch it. Watch it. What number was I doing? 14 and 17. Say yes. Do you see how those related? Did you see how those were? Okay, that's good. Okay. I'm going to do this one, then you can ambulate home. This was a big day. Big day. Ready? Got a bruise there. Probably bruised my hand from doing this. Watch. When you lay somebody on their back, the bony prominence compresses arteries that supply that area of the skin. You got me? So, if this is the crack of my butt, is the crack of my butt getting any arterial blood flow? No. But is the crack of my butt still alive? So, these cells of the skin that make up the crack of my butt are producing CO2, heat, hydrogenized, and they're lacking oxygen. Say yes. So when you turn them over and relieve the pressure, all of the arteries that supplied that area of skin will dilate. And where does arterial blood always go? The path of least resistance. Tell me you're following me. So that area will turn red. So areas when you relieve the pressure that lack blood flow will turn red. And the longer they stay red, the longer they lack blood flow. If they stay red permanently, that skin is going to die. How long can skin live without blood flow? About 4 hours. But they don't want you to wait 4 hours for you to turn them. That's why they do it every 2 hours, because you may be updating your Facebook status, right? And forget to turn Uncle Jab over in the room. What's that?
Is that how they get like bed sores?
That's exactly how they get like bed sores. Now watch. Watch. Then you can ambulate. Watch. I'm going to relate everything, and then you can go home and you can realize this is a big day, Autumn. Autumn, look at you, man. Like you look like you got a deer in the headlights look on you. Like, ooh. Here we go. This was a lot of stuff, huh?
Oh, yeah.
And we're caught up now. What are you gonna do? What do you want from me, huh? There were videos on this stuff. Did you watch them?
Yeah.
Don't hate. I was gonna tell you something, but I'm not even gonna do it. I can't waste my breath anymore. Ready? I'm gonna explain this. This is a sodium potassium pump. What does it require? I'll just tell you, ATP. Watch. When you lack blood flow, you're not getting any oxygen to the skin cells. So aerobic metabolism will stop. Got me? Potassium's going to leak out. Sodium's going to leak in. What do you need to make the sodium potassium? I'll just tell you, you need ATP. Glucose to pyruvate will predominate. Right? Can pyruvate get into So pyruvate builds up, right? Impermeable to the cell membrane, so it will produce lactate. Lactate will get into the blood, and because you've compressed arteries, no blood's getting to it, so no blood's leaving. So lactate is start building it up in the blood. So the local pH is going to drop. Say yes. Inside the cell, the pH is going to drop, so enzymes and metabolism are going to be jacked up, right? That means there's no ATP to make the sodium-potassium pump work. Sodium will leak in, potassium will leak out. The sodium-potassium pump don't work, so water will follow the sodium, and the cell becomes hypertonic to the blood, and the cell blows up. That's why it stays red permanently, because potassium is a massive arterial vasodilator. When the cells die, all the potassium from the cell goes into the blood. That's why it stays dilated permanently. The education of Gateway Technical College.